Hello, and welcome to the Pediatric Brain Tumor Foundation's webinar, Addressing the Challenges of Posterior Fossa Syndrome. My name is Heather Held, and I am the National Family Support Programs Manager for the Pediatric Brain Tumor Foundation. We are honored to have you joining us today for this important webinar. The PBTF provides programs and resources to support families facing a pediatric brain tumor diagnosis throughout their journeys. We will provide some links to those programs and resources at the end of today's webinar and in an email to follow. Before we get started, I do have a few guidelines to review today. You are muted for this webinar and your video is disabled, but we welcome questions during and after the opening remarks. Please type your questions into the Q&A feature found at the bottom of the Zoom window. We will not get to every question, but we will try to get to as many as possible. Today, we'll hear from our presenter, Dr. Darcy Raches, and then two fathers will join her for a panel discussion. Kathy Riley, our Vice President of Family Support, will host the Q&A portion of our webinar. Dr. Raches is a pediatric neuropsychologist in the section of neuropsychology at St. Jude Children's Research Hospital in Memphis, Tennessee. She provides neuropsychological assessment and consultation for children with hematological and oncological diagnosis. Dr. Raches is the lead neuropsychologist to the acute neurological injury team at St. Jude, an interdisciplinary group of rehabilitation professionals and other medical providers at St. Jude. In this capacity, she provides brief assessments, tracks cognitive progress, and provides cognitive rehabilitation for children who have experienced acute neurological injury related to their diagnosis and/or treatment, particularly in posterior fossa syndrome and stroke. Dr. Raches is actively involved in the education and mentorship of pre- and post-doctoral students at St. Jude and other institutions. She is a member of the board for the Posterior Fossa Society, an international group of healthcare professionals interested in the study of posterior fossa syndrome. She is an active clinical researcher with a focus on the cognitive effects of cancer and cancer-directed treatments, and a special interest in posterior fossa syndrome, post-operative pediatric cerebellar mutism syndrome. It gives me great pleasure to introduce to you all today, Dr. Darcy Raches.
Thank you for the introduction. Very excited to be with you all today and to talk with you about this topic that's very near and dear to my heart. Next slide, please. The day, we'll go through each of these, talking about the definition of posterior fossa syndrome and the associated features, identifying factors that place some individuals at greater risk for experiencing posterior fossa syndrome, and then identifying some of the ongoing physical and cognitive changes that are associated with posterior fossa syndrome, as well as some intervention strategies that will go along with each of those. Next slide, please. Start off first by defining posterior fossa syndrome. And when I meet with families, this is where I generally start. So really looking at what is the posterior fossa and how does posterior fossa syndrome get its name. So here you see an image of the base of the skull and the brain tilted up and back from it. And you see in green is the anterior fossa or front space. In red is the middle fossa or middle space. And in blue is the posterior fossa or back space of the skull. So the back of the base of the skull. And you can see above it the structures that sit within that region, the posterior fossa structures. And damage to those structures is what causes posterior fossa syndrome. Next slide, please. Posterior fossa syndrome is a cluster of symptoms within these three different areas of functioning. So there are difficulties with speech, with motor functioning, and with mood. And we'll talk a little bit more about each of those individually. Next slide. We'll start with the speech aspects of that. So there is a difference between speech and language. Speech is the way that we articulate the different sounds that combine to make words, and then words form sentences and paragraphs that convey meaning, and that is the part that's language. So with posterior fossa syndrome, there is significantly diminished speech output, and sometimes that is complete mutism or an inability to speak, and at other times it can be just decreased speech output limited to 1 or 2 word phrases. Now, in posterior fossa syndrome, if there is frank mutism, that does resolve. All patients do begin to talk again. But when they talk again, they sometimes sound different from the way they sounded before their surgery or before they began experiencing posterior fossa syndrome. There may be dysarthria, which is difficulty with articulating different speech sounds. So it will sound like slurring, almost as if someone has something in their mouth that they're trying to speak around as they're making the different sounds associated with words. There may be other changes in speech as well. So there may be differences in volume. Someone might speak with a very low volume. They may speak with variable volume. So they may speak in a more typical volume and then suddenly have words or part of words be very loud in comparison to the rest of their speech. There may be changes in timbre or the quality of speech, and that is sort of the quality of the tone of the voice. It's the sort of thing that lets you discriminate between a particular pitch that's played, say, on a flute and the same pitch played on a trumpet. The quality of the sound is different between those two instruments, and that's the timbre, the quality of the sound, much in the same way there was the timbre quality of voice and speaking. Maybe different speech may have a particularly high pitch, or there may be sort of a lack in variation in pitch or flat prosody. So prosody is the intonation or inflection in speech. It can change the meaning of something that's said. It can relay mood. It is the part of speech that allows you to know the difference between someone saying, for example, that is the door, and that is the door. Same words, only the change in inflection or prosody changes the meaning of what is said there. Please. I will talk about the motor components that are associated with posterior fossa syndrome. And so I'll start here with the things that are most commonly associated with injury to the cerebellum, which are really the motor pieces that we think of when we think about the motor aspects of posterior fossa syndrome. There may be ataxia or difficulty with gait and balance, with walking. That's something that often causes a lot of difficulty for patients who are recovering from posterior fossa syndrome. There may be apraxia or difficulty executing the purposeful movements that are necessary for a particular task. And this is in the context of them being able to perform. That sounds confusing, but if you think about it, someone might be able to open their mouth while yawning in sort of a more reflexive way. But if you ask them to open the mouth, they would not be able to do that. Or they may reach up and scratch their nose if it itched. But if you ask them, touch your nose, they wouldn't be able to coordinate the motor movements to do that. And so that's what apraxia is really about. Dysdiadochokinesia is difficulty with rapid alternating movements. And here you might be familiar from neurological exam that a patient might participate in. So this dysdiadochokinesia is often assessed in asking a patient to tap their hand or their foot, maybe tap a regular pattern up and down, maybe tap the front of their hand and then the back of their hand, alternating back and forth. And there can be difficulties either with the sequencing of that, having two sort of upstrokes in before a downstroke, or having the rhythm of it be off so that some of the pats are faster and some of the pats are slower. And that's the dysdiadochokinesia. Dysmetria is common in people who are experiencing posterior fossa syndrome. That's difficulty with reaching and getting to your target successfully. So there may be difficulty in sort of undershooting or reaching too shallow for the target and missing that way. There may be overreaching or reaching beyond past the intended target. And that is something that also can get in the way pretty substantially in people experiencing posterior fossa syndrome. There may be hypotonia or low muscle tone, and some individuals may also experience hemiparesis or weakness on one side of their body or other. Of note, when someone has posterior fossa syndrome and they have a hemiparesis, it's usually because of an injury more so on one side of the cerebellum than the other side, and the weakness is on the same side as the injury. Next slide, please. So here are some additional motor components that aren't necessarily part of posterior fossa syndrome per se, but these movement disorders sometimes accompany the syndrome and have been associated with greater difficulties with longer term outcomes or more persistent motor difficulties. So someone might have a tremor, sort of shakiness in their movements. They may have dystonia or slow repetitive movements or abnormal postures. They may have athetosis, which is more of a writhing sort of movement. They have myoclonus, or sort of jerking, quick, ballistic, quick reaching out with their arm or their leg unintentionally, sort of a reflexive looking sort of a movement. About the speech and the motor components, and now we'll talk about the mood piece of posterior fossa syndrome. And it's most commonly considered a mood lability. And so lability being rapid changes in mood, more so than would be expected. Most of it is irritability or agitation, inconsolable crying, difficulties tolerating frustration. And usually we've seen that in about 70% of kids with posterior fossa syndrome. Less often, there is inappropriate mood to the other end of the spectrum. So there may be excessive laughter, laughing much more than would be expected given a particular trigger. We see that less common in about 16% of our patients. It's also been described in the literature that you may end up with neither extreme, but truly in between, a flat affect, or really lacking the emotion that you would expect someone to experience. I should say that with the mood lability piece, it's often seen as an exaggerated response to a small trigger. So maybe something that would have been aggravating to someone that they just get very upset about, or something that may have tickled them a bit, but they just begin laughing uncontrollably about it. So it's more about being an exaggerated response to a small trigger. So here at St. Jude, we are looking very carefully at the different symptoms of posterior fossa syndrome to help us get a better sense of the different symptoms and the ones that may tell us more about sort of prognosis later on and whatnot. And we'll talk a little bit more about some research that has come out of this posterior fossa syndrome questionnaire later on. It is worth saying that we complete this questionnaire with every patient here who's treated on our medulloblastoma trial. So that includes children who've had medulloblastoma resection who someone considered they may have posterior fossa syndrome, as well as children who no one has ever considered the idea of posterior fossa syndrome for them, but they have had medulloblastoma resection. Be remiss to not discuss in part of this presentation that posterior fossa syndrome is a term that is used, but there are many other terms that are used to describe a similar cluster of symptoms. And here is a list of terms that are used within the literature, and in rank order here, from the one that is most frequently used down to less frequently used per the Posterior Fossa Society consensus meeting when they were looking to define the syndrome more specifically. Next slide. The Posterior Fossa Society is a group of interdisciplinary individuals who meet on a regular basis and have interest in working with patients who have had exposure that caused posterior fossa syndrome for them. And there is there have been several meetings. There was a consensus meeting that was held back in 2015 when they decided that it was really important to come to a consensus about the terminology that was used. And then there was a consensus paper that came out the year following, really trying to just decide on a particular terminology and definition, diagnosis, and indications for follow-up and monitoring methods. Talk a little bit more about things that have come out of that as well later on. Now that we know what posterior fossa syndrome is, we'll talk about some risk factors that place people at greater risk for experiencing posterior fossa syndrome. And the greatest of that is having a brain tumor, especially one that is in that posterior fossa. And so 8 to 30% of people who have had a brain tumor within the posterior fossa will experience posterior fossa syndrome, though incidence varies depending on different factors. And it is most common in individuals who have had medulloblastoma as compared to other types of brain tumors. In fact, you're 7 times more likely to have posterior fossa syndrome after medulloblastoma tumor resection as compared to any other brain tumor resection. Incidence also varies by molecular subtype of medulloblastoma. Next slide, please. And you see that here, that in the red line at the bottom, that individuals who have a sonic hedgehog molecular subtype of medulloblastoma are much less likely to have posterior fossa syndrome as compared to those who have the WNT subtype or who are in groups 3 or groups 4. All risk factors that have been associated with greater risk for posterior fossa syndrome. And before delving in, I want to say that there is likely some overlap in some of these risk factors. As you can imagine, if you've got a bigger brain tumor, which is one of the risk factors, then it's more likely that both halves of your cerebellum are involved, which is another risk factor. So there's a lot of overlap. Some risk factors that have shown again and again to be associated with posterior fossa syndrome. And then there are some that have been shown in a particular study or another to be associated, or there may be competing evidence. And so those risk factors with the greatest evidence are listed at the top here, and then sort of going down toward the end. Next slide, please. Shown more in our more recent work here at St. Jude to potentially be associated is the expertise in the surgeon who is performing the resection surgery. And so here I'll orient you to this image. The bars that are in green and red are the posterior fossa syndrome groups that are broken down. And then those who didn't have posterior fossa syndrome are represented in the blue bar. And you can see that those who had surgery at a higher volume center, which are those that have 100 cases per year of pediatric neurosurgeries, or resection by a pediatric neurosurgeon, or facilities within the United States that have an accredited fellowship program in pediatric neurosurgery. There's a much lower risk for a patient experiencing postoperative posterior fossa syndrome if they had surgery in one of those centers versus a center with a less experienced surgeon. Now we'll talk about sort of the course or trajectory of recovery after posterior fossa syndrome and the ongoing physical and cognitive challenges that are associated with that. And we'll talk a little bit about interventions to address those. So posterior fossa syndrome is known to have this delayed onset. Hours or days after surgery, it will begin. And most often within a day or two after surgery. And essentially, if you are without symptoms of posterior fossa syndrome at a week after surgery, it's probably pretty likely that you won't develop it. From there, there's gradual improvement in the symptoms of the syndrome in the days and weeks and months that follow. An important time for rehabilitation services to be involved. So occupational therapy to address some of the motor concerns, speech language therapy to address some of the speech and language concerns, as well as swallowing if that is an accompanying issue. Next slide. Posterior fossa syndrome historically was to be a transient syndrome that didn't last very long. But as more and more research was done, it was discovered that truly there are persisting difficulties. And so there's been a lot of research done more recently looking specifically at that. Slide. Earlier study that was done, and they defined severity in terms of duration of symptoms. I'll say that in advance of this talk, there were some questions that came through, and there were several that were about severity. So this will answer some of those questions. So this Robinson et al. Article talked about severity and described symptoms as being mild if they lasted several days but less than a week, moderate if they lasted more than a week but less than a month, and severe if the symptoms lasted a month or more. And so then they classified individuals as having mild, moderate, or severe posterior fossa syndrome based on how many symptoms of what severity they had. So if a patient had 2 or more features that were severe, then they would be considered as having severe posterior fossa syndrome. Moderate if they had 2 or more moderate symptoms, or if they had 1 moderate and 1 severe symptom. And then all others were considered to have mild posterior fossa syndrome. Was that those who had more severe symptoms initially, essentially in that first month after surgery, were more likely to have more severe symptoms later on in a year follow-up after. And that was true for the ataxia that they experienced, continued difficulties with speech language dysfunction, and cognitive difficulties as well. And so those with this more severe posterior fossa syndrome had substantially greater needs at the 1-year follow-up time point as compared to those who had even just moderate symptoms. Other study, this is our group here at St. Jude, looking at severity defined in a different way. And so looking at the substantially reduced speech in posterior fossa syndrome and dividing that posterior fossa syndrome group into a PFS1 group that had a period of frank mutism and a PFS2 group that didn't have frank mutism, but did have substantially reduced speech. So only able to speak in 1 or 2 word phrases. And what was discovered was that having had a period of frank mutism associated with posterior fossa syndrome was associated with greater difficulties in returning to walking independently. Now, I should say that this recovery of independent gait here was defined as being able to walk 10 steps independently. So it's not as if they were walking around in their day-to-day independently, but they could walk at least 10 steps or about 15 feet independently. And another interesting thing to point out here is that if you do look at that blue bar, which represents the children who had posterior fossa syndrome with mutism, there was continued recovery of gait for a fairly long amount of time. So gait does continue to recover for several months and years after surgery. Now, when you think about the cognitive outcomes or talking about the different thinking skills, there are greater difficulties that are seen with more aggressive tumor type or more aggressive treatment, which often comes hand in hand. This is a study that looked at children a year after their initial diagnosis, and to control for those differences in tumor type and more or less aggressive treatment, they matched children based on those factors and also for age. And what they found was, in comparing comparable children, those who had posterior fossa syndrome had greater difficulties in different thinking skills 1 year after their initial diagnosis than those who had similar treatments for similar tumors but didn't have posterior fossa syndrome. And the numbers here are scores. You can see standardized scores and standard deviations here. And the greatest difficulties at that 1 year time were really speed and information processing, and how quickly they could do pencil and paper tasks, which is not particularly surprising given the motor components that are commonly associated with posterior fossa syndrome. But all these other areas, there were also greater difficulties compared to similarly treated peers, though I should say most of these are relative weaknesses and not deficits. Next slide, please. This study also looked at academic abilities. And again, there was significant differences between those treated for similar tumors with similar types of treatment. Those who had posterior fossa syndrome had significantly lower scores compared to those who did not have posterior fossa syndrome in reading, spelling, and math areas. But those lower scores still were only in the low average range compared to other children their age. And so not deficits per se, but lower. Next slide. Some cohort was followed up to 5 years later on, and it was noted that there was significant decline in reading from prior testing points for individuals, and that those who had posterior fossa syndrome had a greater risk for having greater difficulties. Though, of note, at least a third of the participants who had posterior fossa syndrome had such initial deficits that they weren't able to participate in the baseline evaluation before they started radiation therapy. So some of the more severely affected patients with posterior fossa syndrome could not be included in the study. It was then followed up for a full 5 years. And they had lower scores at 1 and 3 and 5 years compared to what would be expected for their age in overall thinking skills, speed in completing tasks, and attention and working memory. Though the processing speed, as we described before, was apparent very early, a year after diagnosis, and continues to be consistently a problem over time, whereas problems with attention and working memory don't tend to show themselves until later on, 5 years later. Caregivers, when they were asked about concerns about behavior and mood and other functioning, didn't notice any concerns in their children. These are times in thinking of the academic and thinking skills that neuropsychological evaluations can be particularly helpful in finding what a particular child's relative strengths and weaknesses are, and making specific recommendations based on that, which can help with school planning, especially identifying whether a Section 504 plan might be appropriate or an IEP, an individualized education program, to address some difficulties if a was having any of those. The slides that I had to share, and I'm eager now to join the two fathers we have on our panel to ask and answer any questions that people might have.
Thank you so much, Dr. Raches, for your presentation. So much information packed into those slides, and we already have a lot of questions that have come in. So please, our participants, feel free to keep typing your questions. We'll get to some of those shortly. We won't get to every question, but we'll answer as many as we're able to. I'm Kathy Riley, Vice President of Family Support for the Pediatric Brain Tumor Foundation, and it gives me great pleasure to introduce two fathers who will join Dr. Raches today for our Q&A. Chris Riley is the father of Peter, a long-term survivor of medulloblastoma who experienced posterior fossa syndrome following surgery in 1993. He served as a founding board member of the WECAN Pediatric Brain Tumor Network in California, and currently serves on the Pediatric Central Institutional Review Board for the National Institutes of Health, overseeing pediatric cancer research for human subjects protection. He is a Los Angeles-based screenwriter, author, and film professor. Stephen Bailey is father to Abby, who was diagnosed with a high-grade brain tumor in 2018. Following an 8-hour brain tumor resection, Abby suffered from posterior fossa syndrome, which left her completely unable to speak, swallow, or walk. Now coming up on 3 years post-treatment, Abby continues to show no evidence of disease. Stephen lives in Atlanta with his wife, Christina, Abby, and her 5-year-old brother, Charlie. I invite our panelists to turn on their cameras. I think you already have, and let's get to our questions. The first question I'll ask of Dr. Raches. There was a lot of information presented in your slides, and is there a central repository or a place that contains some of these findings or white papers or some of the experimental therapy that's happening that professionals could access and or families could access? But where can we go for accurate information about posterior fossa syndrome?
The Posterior Fossa Society does maintain a page where there are citations for some research that has been done in the field by members and other people historically. So especially professionals might go there, people who were interested in reading journal articles. St. Jude has a website they refer to as the Together website. And there is a lot of information on that website about different aspects that have to do with cancer treatments and diagnoses. And there is a page there about posterior fossa syndrome as well. I'm not sure that there is necessarily a central repository per se where articles or different things on this topic could be found, but those are two things that come to mind as a potential resource for families and or professionals.
Great, and perhaps we can receive the link to the Posterior Fossa Society from you and share that with everyone following the webinar. That would be terrific. I want to turn to our two dads now. We have some questions, and Chris, I think I'll start with you. There's a question about, and speak please from your own story, but what happens with the cognitive and academic outcomes a couple of years and further into this journey? You've been at this for quite a while. So would you talk a little bit about your experience?
Yes, so it's from my perspective, it's difficult to separate out the cognitive impacts of treatment like radiation therapy from the effects of posterior fossa syndrome. But Peter's experience was that, based on what I just saw today, we would say he had severe posterior fossa syndrome and saw some dramatic recoveries in that first year, recovery of speech, ability to walk, to swallow, all of those things. In school, we noticed that he struggled, and I think for me, one of the things that I've come to understand in watching Peter is his declines don't mean he's regressing from his own level of achievement, but he's falling further and further behind his peers. He managed to graduate from high school with honors, but it took a lot of support. He is an avid reader today. Here's my hypothesis on why maybe reading is tough. There's the fine motor eye control that's involved in reading that may make reading frustrating for people who are having trouble with their the fine motor control of their eyes. Nevertheless, Peter is a big reader of Harry Potter and Lord of the Rings, and reads through those thick books. But still to this day has trouble with processing speed, so much so that he can't safely cross a street or even a parking lot, because by the time he looks at the traffic and makes a decision about whether it's safe to cross the street, the conditions have changed. And so that's, from a practical standpoint, one of the biggest limits on just his daily functioning in life. So he continues to struggle, but he did manage in the years after treatment and recovery, to the extent that he recovered from posterior fossa syndrome, to get successfully through high school.
Thank you, Chris. Stephen, we have had a number of questions around the topic of recovering speech and recovering movement. Could you talk about what you found most helpful for Abby in aspects of speech recovery and movement? Just you're not as far out, you're a few years into that. So maybe talk for a couple of minutes about that with Abby's story.
Sure. So when we were right after her surgery, this was in 2018, she had pretty, what we would call as well, severe posterior fossa syndrome directly after, like immediately. In fact, it took her took a couple of days for us to really kind of be able to even get any sort of eye movement or communication out of her. And that was tough, obviously, as a parent. But we started, after the recovery of the surgery, we went straight to inpatient rehab. And we started that maybe eight days or so after the brain tumor resection. And, of course, she wasn't able to talk or walk or eat or anything. So we were kind of starting from ground zero. But regarding her speech, it was funny. It was interesting because we were able to make her laugh. And when we were able to make her laugh, that was the only way we could hear her voice. And so we kind of might have stolen a little device that you can record things on. And we made some funny sounds on it. So every time when she would hit this button, it would just make her giggle and laugh. We could hear her voice. And there was this kind of one, we noticed she was making this one kind of humming sound. And she was able to do that. So whenever she was able, we kind of tried to get her to start humming. We weren't pushing her to talk or speak any words or anything, but we just noticed that was the one physical way she could move her vocal cords and actually get sound out. So we just kind of capitalized on that and kept working with her to get her to make this sound. And as soon as she did that, she kind of remembered, I guess is the proper term, how to speak and how to make, an actual, sound projection. So that was a really big milestone for us in the recovery of posterior fossa syndrome. And when she did recover, like immediately after that, her voice was higher pitched, and it sounded different. That eventually, maybe over the course of the next 2 to 3 weeks after that, after she continued to relearn how to speak, her voice did go back to normal, or I would say 95% normal. So that was a big win. And since then, her speech has been pretty normal. Ever since she recovered, then there hasn't been like a chronic speech issue or anything with her journey. So we're grateful for that. And then going off like on the physical movement side, I think Kathy is what you mentioned. We do struggle with her, like just with motor, like gross motor movements. She, like, for lack of better words, can be quite clumsy, and we do know that it's, and to some degree, related to posterior fossa, if not all. And her specifically her spatial awareness and depth perception is not. It's pretty off, and we can notice this like on an acute level. Like, I mean, she could be sitting at breakfast and reaching for like a spoon, or like, trying to do something very basic, and she kind of misses the mark there. So that's probably like the number one thing that we're still dealing with as we, progress. We're now about 3 years out post-treatment, so still trying to understand, even as of yesterday, talking with her teachers at school. We're trying to also have them help us differentiate and figure out what is, normal behavior compared to the class average, and what is behavior that she sees in Abby that, it's more related to her, and what we could probably attribute to posterior fossa syndrome. So.
Yeah. Thank you for sharing that, Stephen. Dr. Raches, we have had multiple questions about speech. And so I want to, this is sort of a two-part question, and if either Chris or Stephen have something to add as well, please jump in. But it sounds like for some of the questions that speech has really been challenging to recover for some of the families joining us today, and speech therapy has been unsuccessful. Sounds are able to be made. So I think that the first part of my question is, what additional interventions or help are available for speech that you are aware of? And secondly, beyond that, in the school setting, is there anything you've seen work in the area of communication with speech, any assistive technology devices?
So with the speech piece, usually technology early on when kids aren't able to communicate verbally or with another means. And especially assistive technology tends to be helpful when the speech piece is what lags and the motor pieces progress more quickly, so that someone is able to press a button or accurately indicate in some way via the assistive technology their response. Therapy is what we recommend when speech problems persist. Though I will say some of those.
One more time, you just cut out. What did you say you recommended?
Sorry, my computer is telling me that my internet connection is unstable, which I
That is
don't
all right.
understand. Attached to the hospital internet. So usually we recommend assistive technology or use that more frequently in the early stages before someone is able to speak, and especially if their speech progress lags behind while their motor progress is more advanced, so that if someone is able to more accurately touch a device to indicate their answer, then they're a better candidate for an assistive communication device, especially one that's more technologically advanced. Generally, we recommend continuous speech language therapy for the other speech difficulties that persist after that. Though some of those difficulties that become apparent after someone begins speaking again, especially that dysarthria or difficulty sort of getting your mouth and lips and tongue in the right place to say sounds of words, or the rate of speech, the rhythm of the speech, some of those difficulties can persist for a good long while and can be pretty difficult to remediate. I think it's important to convey to listeners that they need to be patient, and that just because someone either can't speak in those initial stages or has difficulty articulating something doesn't mean they don't have something important to say, and that they should consider that and wait and allow for time for someone to convey the information that they have in their minds.
Thank you. That is such helpful advice, I think, for those parents who still see that struggle with their children. We have another question about, this is again a little bit more towards the long-term piece. And so I think, Dr. Raches, I'll ask you to address this, and then maybe Chris, I'll ask you to jump in as well. But for someone who has recovered and is walking and talking again and currently doing well academically, do you see children who continue to do well, or do we, with posterior fossa specifically, do you anticipate seeing continued decline, or can there be a maintaining of academic performance?
I can say that Chris answered this question very nicely already. There are some competing forces at play. So there are the cognitive late effects that are a result of the sort of treatment that is associated with posterior fossa brain tumors, especially a more aggressive tumor like medulloblastoma, the chemotherapy and radiation therapy that tend to show later on down the road. And as Chris mentioned, it's not losing skills. It is a failure to gain skills at as quick of a rate as your peers, which shows up as your standardized scores, which are comparing you to same age peers, being lower and lower over time. So children should not lose skills after they already have posterior fossa syndrome. It should be a recovery trajectory from there, but they may gain skills at a slower rate than peers, which is what causes the problem, that gap between the expectation in the environment and keeping up with their peers as they gain their skills at a quick rate, and a child's abilities as they gain their skills at a slower rate. The piece that posterior fossa syndrome contributes is the additional difficulties with processing speed. Again, as I mentioned, I think the component of the cerebellar or motor piece really plays a big role in the extra problems with processing speed that children with posterior fossa syndrome have. But we would expect to see continued gains over time in skills. One of the things that you mentioned earlier was reading and learning to read. I think Chris mentioned this about his son. While he enjoys to read, he might not be the most efficient or fluent reader. And we know from our research that age at diagnosis and treatment can have a particular impact on that. If a child is diagnosed and treated before they have learned those learning to read skills, the phonics skills that letters have sound combined to form words combined to form sentences that have meaning, and you read them get the meaning from them when you read, that children who have their treatment before that may particularly struggle with that process of learning to read compared to kids who are a bit older, who have learned those phonics skills and those early reading skills may have less of a struggle with the reading piece.
I think maybe what I have to add is more of like, how do we as parents emotionally deal with these realities that we just heard described? And Dr. Raches used the term gap, that there's a gap that opens up. And I spent, I would say, several years early on trying to close that gap and believing that if we applied enough therapy and support, we could get Peter caught up. And that, for Peter at least, did not happen. And for me, emotionally, that was a very hard thing to acknowledge and come to terms with. I eventually did come to terms with that. And what worked much better for Peter was to help him develop on his trajectory rather than try to get him over the hump, which frustrated us, frustrated him. Even years after treatment, Peter continued to recover. He took piano lessons, and a left hand, which really we called his lazy hand or his sleepy hand, because he never used it for anything because it was difficult. The piano lessons acted as a kind of occupational therapy for him, and his left hand gained the ability to play the left hand of piano pieces, not perfectly, but at a much improved level. And this was years post-surgery and post-treatment. I think from an emotional standpoint, what has helped me is to let Peter be on his own path and support him on that path without ever assuming there's any ceiling. I don't know where the ceiling is, so we will just keep supporting him. And we're now almost 30 years into this, and we continue to do that. Peter's a happy guy, and he learned to read completely post-surgery because he was in preschool at the time of his diagnosis and surgery, so he did not have those reading skills at that point, and yet has learned to read. But this is a long road, and we want it to be a long road. You know, the thing we wanted at the time of treatment was our children to survive, and but this is part of the cost of the treatment and their survival.
Thank you both for your deep and meaningful insights. I also am thinking that present today, I know, are some healthcare professionals who really want to learn how to best support families, particularly those in the psychosocial field. And Stephen, I wonder if you could speak to what is the best advice to give to the psychosocial team? What were the ways that you and your family were best supported by the healthcare team, early on?
That's a great question. I think maybe just following up with what Chris just said about, like, we were kind of on the same mindset of, okay, let's just keep figuring out how we can get Abby there faster. And, I think a much healthier maybe approach is exactly what Chris just said, is just going at their pace and just coming around them and supporting them with what they're able to do. And, not, it's hard sometimes, like, not to get frustrated, and just as a parent in daily life with some of the behaviors that are associated with all this. But I think as far as like from the clinical side, and like our the teams that were supporting us, especially when we were going through all this in the weeds, I think maybe kind of reinforcing that. That's a tough thing, because when we were handed the diagnosis and the surgery, like the treatment plan and all that, I mean, we took it a minute at a time. And I was going to say, it was, had we known like the scope of posterior fossa syndrome, it would have been much harder for us to go into surgery, So I'm glad we didn't really know that. Our surgeon had mentioned cerebellar mutism as a potential outcome, but we were just like, okay, well, our daughter has a brain cancer, and we just need to get this out of her right now. So that's what we're going to do. So I think, to answer your question in a roundabout way, Kathy, I think that the best support that we got was kind of getting the information that we needed in like timing was important with the information that we got, especially when we were, closer to the diagnosis. And that, yeah, I don't know. I think that's the best I can offer at this point.
Yeah. Great. Thank you. Thank you for that. Chris, do you have anything you would like to add from the parent perspective to that?
When Peter was experiencing posterior fossa syndrome, it was so long ago that it was not a well-recognized syndrome. And so our healthcare team often would say things like, we've never seen this before. So that was not all that helpful. I remember a neurologist coming into the room in the very early days when Peter was not communicating in any way, and asking very skeptically, does he know who you are? And we said, well, we think so. And the neurologist said, well, how do you know? In a way that really kind of challenged the possibility that Peter was still there as Peter. And Stephen, you talked about the laughter as an early response. That was the first time that we knew that it was still Peter. And we had a cassette tape of one of his little friends burping, and we would play that for him, and he would laugh. And I thought, okay, well, that's a low level of humor. I'm going to tell him a joke that requires him to cognitively process it. And if he laughs at that, then I know he's understanding. And he did. He didn't laugh at a joke. So I think providing just the information that kids with posterior fossa syndrome get better, that typically the speech returns, and whether it's a matter of days or longer, I think that can be really important. It's just the encouragement that recovery happens, and recovery can extend over a long period of time.
Thank you, Chris. We're getting close to the end of our time. Dr. Raches, I have one more question for you. There, along with a lot of issues with speech, there is also about achieving improvements, in balance and coordination. And are there long-term interventions that your team has seen at St. Jude that has helped achieve improvements in balance?
These questions are probably better suited for physical or occupational therapists, especially physical therapists. I will say Anecdotally, and I think from the slide where we looked at mutism as a predictor of recovery of gait, we do see improvements in balance and gait continue for a very long time. So whereas some of those specific speech things are difficult to remediate, and if you've got them, and it's hard to improve with some of them, that ataxia and balance, I have seen slow and steady recovery over years and years and years. Just anecdotally seeing patients who a year or two after surgery were still in a wheelchair, and a year or two later maybe started walking with a cane, and a year or two or three after that didn't have one. It is something that I've seen continued recovery with, and especially in those who do continue to get rehabilitation services and continue to work on those things.
Thank you. Thank you to our panelists for today. There was a comment in the chat, which I thought was really characterized our time together today, and that these are challenging times for parents whose kids have posterior fossa syndrome. And there's this fine balance between gratitude, and sadness over what was lost. And you all covered that well today, and helped us sort of sit in that place of bittersweetness, which is hard, but you've provided a lot of hope too. And thank you for that. Thank you, Dr. Raches, for all of your expertise, your experience, and helping us to define the problem and understand better what's happening and possible interventions. We're grateful for each of you for participating in those really meaningful ways today. And I want to thank our attendees as well for your participation and thoughtful questions. And then if we could bring up our resource slide, that would be great. Thank you. So the Pediatric Brain Tumor Foundation has a couple of resources to help with your educational and survivorship needs. The Survivorship Resource Guidebook provides comprehensive information and practical resources for survivors and families, and I think you'll find some really valuable information there to help you in your survivorship journey. That resource can be downloaded today, so you can download that right after this webinar, or you could also order a hard copy online. We do have virtual support groups that are held every other week for 10 sessions and available for families 0 to 5 years from diagnosis, and then 5 years plus from diagnosis. So I invite you to click on that link if you're interested in joining a support group. The goal of that program is to bring families facing similar struggles together in a safe online environment. And we have some new groups starting in April. So if you're interested, please click on that link. Both of these links will be sent to you in a follow-up email later today, as well as the slides being shared with you. And then finally, the PBTF is here to help you no matter where you are in your journey. Please reach out to us to support with additional questions you had today that weren't answered. We're here to help in any way that we can. And we will send you a link to the recording of this webinar and the slides at the email address you registered with. Thank you all for attending today. And please let us know if there's anything else we can do to help. Have a good day.